You are on streaming now. ಮಾತಾಡ್ಕೊಂಡು ಹೋಗ್ರಿ.
Okay, good afternoon dear students. Today I am going to start one more new topic, varicose veins. This comes under venous disorders. So before, you must have heard plenty of times in clinical in hospitals varicose veins. So first and foremost is, what is varicose vein? You should know about the definition of varicose vein. So there is a definition. Usually majority times people will come to only dilated tortuous veins or varicose veins. It is wrong. Okay, there is a proper definition for varicose vein. Varicose veins are defined as dilated, usually tortuous, means it may or may not be tortuous, and it's subcutaneous veins of 3 or less than more than 3 mm in diameter, measured in the upright position. You have to measure it always in standing position with, last but not the least, very important thing is demonstrable reflex. Means you have to demonstrate the reflex either by clinical or by radiological method. There should be a reflex. Then only you call it as a varicose vein. It is a proper definition for varicose vein. So if you see this image, you can see dilated veins over the lower limb. Whenever you see in hospital or patients, immediately you come to know these are varicose veins. So this is also image showing varicose vein over the lower limb. Now coming to the anatomy of the superficial and deep veins of the lower limb. Okay, before discussing this varicose vein, we should know some of the surgical anatomy of the superficial and deep veins. So in the lower limb, this venous system we have divided into 3 groups. Superficial venous system, it consists of great and short sequence veins. Deep venous system, and also one more system which connects between superficial and deep venous. It is called perforator or communicating system. Okay, these are the 3 systems you can see over the limbs. And you see, this is the venous drainage of the foot. I already told, usually over the foot. Okay, you see, this is the medial marginal vein. It continues as a, this medial marginal vein, this continues as a great sequence or long sequence vein, and on the lateral side, this is the short sequence vein. It continues via the lateral marginal vein. It continues as a short sequence vein. Then you see the diagram of the great sequence vein anatomy. Okay, as it passes, it receives some of the tributaries and ultimately ends into the femoral vein. Whereas in case of short sequence vein, you see the short sequence vein. Okay, here we also get the region of the popliteal region. It enters into the popliteal vein. And coming to the deep vein system also. This is the deep vein system. It consists of the anterior, posterior, and peroneal veins. These are all 2 in numbers. Okay, it continues as a popliteal vein. Again, it continues as a superficial femoral vein, and then palmar femoral vein. And again, continues as the iliac veins. So this is the deep venous system. Then one more system called communicating system, which means which communicates into the superficial and venous systems by perforators. Okay, you should know some of the perforators all along the venous channel, and they are named perforators. Okay, these are all called ankle perforators. Means these are the perforators which are in the ankle region. It's also called as May or Kushner's perforator. And at the lower part of the leg, these are called pocket, and here gastrocnemius perforator is also called as boiled perforators, and mid-perforators, mid-thigh perforators. This is a thigh, this is called dot perforators. Okay? So these are all the plenty of perforators are there. Okay? Any of the perforators which will become, if it becomes incompetent, then causes varicose. So before discussing, we should know about the pathophysiology of the varicose vein development. How the varicose veins will develop. So normal blood pressure in the lower limb in standing position, okay, especially at the foot, reason it's about 100 millimeters of mercury on standing position. Okay? It becomes 32 millimeters of mercury on the arterial ends. Okay? At arterial ends it becomes less. Again, arteriovenous and also capillaries, again it becomes less. Then at the end of the valvular end it becomes 12 millimeters of mercury. So initially it was 100 millimeters at the standing, and gradually when it ends via arteries, arterioles, capillaries, and at the valvular end it becomes 12 millimeters. And then minus 5 millimeters of mercury at the upper end of the vena cava. Okay, when it enters into the vena cava, actually it's a negative pressure. Then calf muscle pump, which is augmented to a lesser extent by a thigh and the foot pumps. What happens? On standing position, it's about, I already told, 100 millimeters of mercury. Okay, during muscle contraction, okay, whenever you walk, okay, the calf muscle will contract. By that time, okay, the pressure in the veins system rises 200 to 300 millimeters of mercury. Okay. During muscle relaxation, the pressure falls and blood from the superficial vein enters the deep veins through the subcutaneous junctions and perforating veins. So during muscle relaxation, the blood moves from superficial to the deep system. So here, the net reduction in the pressure of the superficial system is dependent on the presence of the pressure gradient between the thorax, neck veins, perforating veins, and superficial veins, which first contain competent valves. Okay? So this is the net reduction in the superficial system. It combines all these factors. Okay? Any changing of these factors which cause increasing the venous pressure. Okay? Any absence of one or more of these results in venous hypertension. Okay? This is one of the important terminology, venous hypertension. So what is venous hypertension? Okay? These are some of the causes or factors which causing venous hypertension. So one of the factors is varicose vein. So the development of varicose vein is because of venous hypertension. So what are the factors which cause venous hypertension? There are two important factors. One is pressure gradient dysfunction, and second one is venous system dysfunction. Okay, these are the two factors. Next is, what is pressure gradient dysfunction? Pressures. Okay, so the venous system pressure always varies, depends on the increased abdominal or thoracic pressure or decreased calf muscle function. Okay, so these are all some of the causes for increased abdominal or thoracic pressures, like COPD, pregnancy, obesity, large tumors in the pelvis or abdomen, or even constipation. These are the some of the causes where increased abdominal or thoracic pressure occurs. Whereas in case of decreased calf muscle function, this is because of whenever you walk, there will be a calf muscle will act. Okay? In case of immobility or ankle joint fusion, or in case of paralysis, in case of hospitalized long-standing patient duration, usually it causes decreased calf muscle function, and also it is responsible for venous hypertension. Okay? This is first category. Okay? Then second one is dysfunction of the venous system. Okay? So in dysfunction of the venous system, there are several defects, whether it be in the venous or structural deficit or because of venous occlusion. Even in case of venous occlusion also cause venous hypertension or venous compression also causes venous hypertension. Some of the venous structural defects, that means it related to the veins. Okay? The defects is within the veins, all these things. Okay? This is because of variety of causes like valvular agenesis, valvular incompetence, venous dilatation, venous tortuosity, loss of vein wall compliance, loss of venous stone, or AV fistulas, arteriovenous fistula. So these are all factors in relation to the venous wall. Then because of occlusion, the luminal occlusion of the vein, because of agenesis of the venous system, or thrombosis, or iatrogenic, or because of trauma. Okay, these are some of the causes for venous occlusion. And venous compression from the outside. So here some of the causes: Turner syndrome, pelvic or abdominal tumors, or even post-radiation pelvic or abdominal radiotherapy. Post radiotherapy also, because of fibrosis, it causes pressure over the venous system and cause venous hypertension. Okay. So what are the clinical features of venous hypertension or varicose vein? So varicose vein is a component of venous hypertension. So what are the clinical features of varicose veins? So the adult prevalence is 40 to 30% in women and 15% in men. Here, women are more common. These factors include prevalence. It includes age. When coming to the age of the patient, usually between 45 to 47 and between 55 to 64 years, age around 41 to 55% respectively. Means between 55 to 64 years, the incidence is more common. Around 55% of the cases you can see majority of varicose veins between in this age group. And ethnicity, ethnicity also influences the prevalence of varicose veins. And also body mass and height. Okay? Whenever there is a increase in body mass or even increase in the height, also causes varicose veins. And also another factor is pregnancy. Even in pregnancy also you can see there is the risk of, and also family history. Evidence supports familial susceptibility to varicose veins. One more important here is occupation and lifestyle factors. Okay? So earlier what we thought is, especially whenever you ask in examination what is the cause for varicose veins, usually in long-standing like surgeons or the bus conductors. Okay? Nowadays it is incorrect. Okay? There is inconclusive evidence regarding increased prevalence of varicose veins in smokers or patients who suffer constipation and occupations which involve long-standing. Earlier we thought that because of long-standing varicose vein occurs. That is wrong. So how will you classify varicose veins? Okay, there is a classification system is there, that is called CEAP classification. Okay, this CEAP classification, C implies clinical, E means etiological, A means anatomical, and A means pathological classification. So out of this CEAP classification, clinical classification is important. Whenever you do the diagnosis of varicose vein, we have to tell according to this classification. What is this clinical classification? In clinical classification of varicose veins, they will categorize into C means clinical 0, 1, 2, 3, 4, 5, 6, 7. Okay. What is C0? Means no signs of venous disease. C1 means telangiectasia or reticular veins. If there is only telangiectasia is there, then you will call it as a C1 disease. What is C2? C2 means varicose veins. Okay. Whenever you see more than 3 mm diameter veins over the limb, then you call it as a varicose vein. This is a C2 disease. Then presence of edema comes under C3. Then again C4 again is divided into A and B. The presence of pigmentation or eczema, it comes under 4A. 4D means lipodermatosclerosis or atrophic branch. One more C5 disease means it's a healed venous ulcer and C6 is active venous ulcer. If there is a healed venous ulcer C5 and there is a ulcer is there, then it comes under C6 category. Okay. Again, this C0 to C6 each is again divided into S and A. Means S means symptomatic, A means asymptomatic. Okay. In case of in all these categories, if there is a presence of symptoms like pain and other things, usually comes under S, or absolutely no symptoms, A. The next one is E. E implies etiological classification. Again, it is subdivided into C means congenital, B means primary, and S means secondary. Usually, congenital causes will be there. Primary means the exact etiology is not known, and in secondary means there should be some secondary, there should be some causes like varicose veins viola. N means no venous disease identified. So, what is the cause for this primary varicose veins? I already told the name itself. Primary means exact etiology is not known, but there are some factors which these are the factors where there is a changes in the vessel wall, where when they are identified, these are some of the changes which causes primary varicose veins. Like one is dysfunctional smooth muscle cell proliferation, elastic position, decreased elastic content, and fourth one is increased metalloproteinases. These are the changes. These four changes you can see in the primary varicose vein wall. These factors which lead to the venous dilatation because of weakening of the venous wall, which causes venous dilatation, and again can cause secondary valvular incompetence. What is the cause for secondary varicose veins? The secondary means already there should be some cause in it. The etiology exactly some of the like post-thrombotic link. Post-thrombotic, especially in case of post-DVT, you must have heard deep vein thrombosis. Okay, whenever patient suffers from deep vein thrombosis, then later patient will develop varicose veins. And one more congenital abnormalities such as Klippel-Chenore syndrome. It is one of the here in this syndrome there is a grossly dilated veins you will see over the limb, and also there is a multiple arteriovenous fistula. So this is also one of the cause for secondary cause for varicose veins. Then one more classification is anatomical classification. Anatomy, A implies anatomy, anatomical. Here you can see S means superficial veins, P means perforated veins, and D means deep veins, and N means no venous location identified. Then P, CEAP, last one is P. P implies pathophysiological classification. Again here it implies R means reflex. If there is a reflex, PR, then O means obstruction is there. R means both reflex and obstruction, and N means no venous pathophysiology identified. So coming to the clinical features. Clinical features. What are the symptoms? The most common aching or heaviness. This is the most common symptom in case of varicose vein, which typically increases throughout the day or with prolonged standing and is relieved by elevation or by compression hosiery. Okay? So this is the most important, most common symptom is aching or heaviness. Usually patient will complain at the evening time, patient will have a aching or heaviness. So this pain is relieved by whenever patient after taking rest or after applying a elastic compression hosiery. Other less common symptoms include sometimes along with varicose vein you can see ankle swelling, sometimes even itching also patient will complain, and other complications like rarely you can see even bleeding also after patient sustains trauma or superficial thrombophlebitis, eczema. and even lipodermatosclerosis and ulceration. So these are all some of the complications. When the varicose vein develop complications, again patient will develop all these problems. What are the signs? Okay, if you see the limb of the patient, okay, it's a lower limb. Most obvious sign is presence of tortuous dilated subcutaneous veins. Easily you can see, whenever you see the limb, you can see the tortuous dilated subcutaneous veins, and even you can identify whether which system is involved by looking these dilated veins. Okay, if it is over the medial plane of varicosities, it implies long sickness incompetence, or long sickness vein is involved, or posterior lateral of side, then we see that we can pick up this the short sickness incompetence. Okay. By looking the site of dilated veins, whether it is long sickness or short sickness veins, easily you can identify. These are the signs. Okay. If you see this one, here it is the anterior aspect, definitely you can tell this is the long sickness varicosity. Even in this image, okay, you can see this is the long sickness varicose vein along the medial aspect, here and also. So this image showing long sickness vein. Here this is radiologically they have marked. These are all preoperative marking. We will discuss later. And over the top muscle, here you can see the dilated veins on the top muscle posterior aspect. Then it indicates short sickness incompetence, or short sickness vein is involved. Okay. So most important sign is dilated tortuous veins over the limb. But other than that, sometimes even other signs also commonly found in varicose veins and in venous hypertension. Not only these dilated veins, even some other signs also you will see. What are all those? They are telangiectasia. What is telangiectasia? They are dilated intradermal venules. Veins means it is bigger. Venules means these are less than 1 millimeter in diameter. Very small veins. This may be mild or severe. These are all very small veins. Okay, less than 1 millimeter. You can see over the thigh or over the calf region. Less than 1 millimeter. These are called telangiectasia. It's also other name for this telangiectasia is also called as spider veins or thread veins or even hyphen webs. Okay? It will call by other these names. If you see this image, okay, so these are all not varicose veins. Okay? Varicose veins means it's all bigger vein. Okay? It should be more than 3 millimeter in diameter. So these are all very less than 1 millimeter. Okay? These are called telangiectasias. Okay? So whenever you see this blue mark, like pencil marks, okay, this indicates these are not called visible signs. Okay? These are telangiectasias. One more entity are reticular veins. What are reticular veins? You call it as reticular veins. They are dilated subdermal veins. It is little bigger than telangiectasias. Here the size is 1 to 3 millimeters in diameter. Okay? So this presence of telangiectasias and reticular veins are purely a cosmetic problem. So if you see this image, this is the reticular veins. These are bigger spider veins, reticular veins, less than 1 millimeter and between 1 to 3 millimeter in diameter. Then SSMC. What is SSMC? There is a large growing varicosity which presents as a lump emergent when standing and disappearing when recumbent position. Okay, this is a growing varicosity. You see here on standing position, you can see this is a varicose vein. Sometimes it mimics like a hernia or femoral hernia. Then what is coronal phlebectomies? This is also one of the signs. They are fan-shaped patterns of small intradermal veins on the medial or lateral aspect of the ankle or foot. So this coronal phlebectomies you can see at the medial or ankle of the ankle region. and it's also called as valvular or ankle flares. So this is corona phlebectomy. It looks like this. Whenever you see, this is the sign. It indicates this one. These are called corona phlebectomy. It's also called as valvular or ankle flare. One more entity called arteriovenous plant. What is arteriovenous plant? It is a localized white arteriovenous skin, frequently surrounded by dilated capillaries and hyperpigmentation, usually seen around the ankle. Okay, this is also sign you can see around the ankle. So in this image, this is a white patch. This is the arteriovenous plant. Then pigmentation. Sometimes you can see the pigmentation, sometimes in long-standing cases this is more obvious. This is usually a brown discoloration. This is because of deposition of hemosiderin over the skin, most frequently affecting the gaiter area. What is gaiter's area? Gaiter's area means it is the area between the muscles of the calf and the ankle. The area is called gaiter's area. You see, in long-standing cases, in this discoloration, it is called pigmentation. Then superficial thrombophlebitis. So it's also one of the sign. Okay, you can see hyperemic over the venous channels. Okay, this is called superficial thrombophlebitis. Means here inflammation of the superficial venous system. Here it means the formation of the blood clot occurs or obstruction occurs here, as well as inflammation. Then eczema. Eczema means this is an erythematous dermatitis which may progress to blistering, weeping or scaling eruption of the skin, not to be confused with contact dermatitis. Okay? This eczema, the lesion appears similarly like contact dermatitis. Okay? So this is erythematous dermatitis. Okay? This erythematous dermatitis is because of this is a sign involves in the varicose veins, whereas this also looks like the same, but this is contact dermatitis. Here the pathology is different. Okay? Dependent pitting edema. Whenever capsically increases throughout the day and is relieved by elevation and compression hosiery or bandaging. So this image shows the edema, dependent edema. Okay? This is one of the, in case of long-standing cases, varicose veins, you can see all these signs. One more is lipodermatosclerosis. What is lipodermatosclerosis? It is a localized chronic inflammation, fibrosis of the skin and subcutaneous tissues of the leg. It indicates it's a sign of severe chronic venous disease. It is called lipodermatosclerosis. So this is the image showing dermatosclerosis. This is also showing lipodermatosclerosis. And ulceration is a full thickness epidermal defect. Ulceration is always in case of venous ulcers, only epidermis will be lost, most frequently affecting the gaiters area. I already read what is gaiters area. So typically the venous ulcer looks like this, epidermal defect disease. This also is showing the venous ulceration. Coming to the investigations. What investigations? Whenever you see a varicose patient and if it is symptomatic or you see all these problems, you have to subject it for investigations. What investigations? Tourniquet tests and the use of handheld Doppler have now largely been done. Nowadays, we are not doing these tourniquet tests. Okay, these tourniquet tests only in case of clinical practice. Okay, if you come to the ward in the case of this one, we will do to rule out the varicose vein incompetent perforators, whereas nowadays even these tests are also abandoned. One of the most important tests we are going to do in case of varicose vein is duplex ultrasound imaging. Okay, this is the gold standard imaging technique in the case of varicose vein. Okay, without this type of investigation, without this duplex ultrasound, we are not going to manage the varicose vein case. Okay? So it is the mainstay of investigations for varicose veins. Okay, we go to the radiology department, how they are doing the duplex ultrasound for the examination of varicose veins. Usually they will do it on the patient in the standing position. Even the radiologist, they will start from a cephalohumeral position and they will assess the veins. So this is the position of the venous duplex ultrasound scan, and over this one there is an antegrade or retrograde flow. Retrograde means reverse flow. Whenever there is a reverse flow, this is the venous vessel. If there is a normal flow, the image is color coded. It appears like a blue. Or if there is a reverse flow, you can see there is a incompetent valve or perforator you can assess. So what is the aim of the duplex scan is, these are all the advantages of doing duplex ultrasound. Here the presence of the reflex you can identify whether it is in which way, whether it is superficial or deep or between the competent perforators. The exact distribution extent of the reflex, even where it is there, the exact location of the incompetent perforators, and also extent of the reflex, whether the reflex is mild or moderate also you can assess, and even the presence of the obstruction. Obstruction means in case of deep venous thrombosis or superficial thrombosis also easily identified, and the suitability of the incompetent superficial veins for the different treatments available also you can, based on that you can assess the diameter, extent, tortuosity, circumference, everything you can identify. Even the presence of thrombus, whether it is in the superficial or deep venous system, and an indication of a pelvic source of the reflex or obstruction. Even you can have to assess the pelvic region by doing this reflex ultrasound. Pelvic veins. Sometimes the cause of varicose veins is in the pelvic side. And so after doing the duplex ultrasound, they will mark. They will mark the perforators using duplex method. Before surgery, they will mark like this with the skin pencil. So this is the markings for the lungs, SSMC. The pelvic and iliac veins may be investigated using trans-abdominal or trans-vaginal duplex ultrasound. Usually the duplex ultrasound do it via trans-abdominal, or via trans-vaginal, especially to denote any pelvic pathologies. And very occasionally investigations other than duplex are required, and these may be non-invasive such as MR venography, or invasive such as contrast venography or intravenous ultrasound. The use of varicography has become historical. Nowadays varicography is not usually done. What is varicography means? It is an injection of a contrast material injected directly into the superficial varices. This is useful in patients with recurrent varicose veins or with complex anatomy. So this is the image showing the varicogram. Usually not for all the routine, we are not doing this investigation, only in case of complex cases we will do. Nowadays even this is also historical matter. One more is descending intravenous venography. In this case, the contrast is injected via deep veins, then it's called descending intravenous venography. And one more entity, that is magnetic resonance MR venography. MR venography is useful when the lower varicosities appears to arise from pelvic vein incompetence. To assess the pelvic veins, again this MR venography is advisable. Then after identifying the incompetent perforators, or after assessing the patient of a varicose vein with a duplex ultrasound, then the next line of management, how we are going to manage this varicose veins. Patients who have asymptomatic varicose veins can simply be reassured. Okay? Whenever you see the patient with the dilated veins over the limbs and patient does not complain anything, then no need to advise for them for any treatment. So when you are going to indication, so that's indications for intervention. Okay. Some of the indications, then only you can advise it for the variety of procedures. C2 disease. What you mean by C2 disease? I already told in case of CEAP classification. C2 means presence of varicose veins. Okay. C2 disease associated with bleeding. Just the presence of C2 disease is not the indication for surgery. Even vessels are dilated more than 3 mm in diameter, okay, no need to advise surgery. But there is a associated bleeding or there is a presence of superficial thrombophlebitis or symptoms which are impairing quality of life, which is symptomatic. Okay, C2 disease. With all these things, you have to advise for management, advise for intervention, or C3 disease to C6 disease. Maybe all the other things, if it is there, C3 disease, I already told, like thrombophlebitis, or even there is a pigmentation, eczema, ulcerations, etc., etc. These are all comes under this C3 disease. Then you have to advise for intervention. So these are the indications for intervention. We just presence of a varicose vein without any symptoms, no need to advise. Okay. So what are the treatment modalities here? If you see this one, there are several methods in treating the varicose vein. By compression hosiery, it's also known as elastic stockings. You think what you call elastic stocking is also called as compression hosiery. Then one more method is ultrasound-guided sclerotherapy. Okay. Here again there is sclerotherapy. Nowadays with the help of foam we will do. Therefore ultrasound-guided sclerotherapy. Then endovenous laser ablation. Here the venous system they will ablate by using the laser ablation. It is called endovenous laser ablation. And one more energy, that is radio frequency, by using energy for radio frequency ablation. Then by surgery also you can manage this case. And even recently, okay, even catheter directed sclerotherapy and mechanical ablation. And even by using endovenous glue. Okay. So these are all variety of mechanisms there for treating the tortuous. To discuss about what is compression hosiery. Compression hosiery is also called as elastic stockings. It comes under below knee or above knee length. And this compression hosiery is again classified. It depends on the, so there is a particular classification, that is British classification of compression hosiery. Depends on the whether it is what is class 1 stockings, class 2 and class 3 stockings. Class 1 means it exerts pressure of 14 to 17 mm mercury. In class 2 stockings, it exerts 18 to 22 mm mercury, 24. In class 3, it is 25 to 35 mm of mercury. So it depends on the this is British classification of stockings. So this image showing the below knee. This is the knee length, below knee stockings, and this stocking. This image showing the above knee stockings. Okay. So this is also called as compression hosiery. Then one more is ultrasound-guided foam sclerotherapy. This ultrasound-guided foam sclerotherapy means it involves the injection of detergent directly into the superficial veins. Okay. The most commonly used agent is sodium tetrabenzyl sulfate. Okay, in case of this foam sclerotherapy, this agent they will use. What is the function of this agent? Is the detergent destroys the lipid membranes of endothelial cells, causing them to shed, leading to thrombosis, fibrosis, and obliteration. The mechanism of action is sodium tetrabenzyl sulfate. So this image showing the foam sclerotherapy. Before that, they will cannulation of the varicosities by using the ultrasound, and you can inject the foam sclerotherapy directly into the vein. In this image, how to create the foam? There is a method. Okay? This is called a Tisser's method. Here, first When one syringe they will take only the sclerosing agent and in one syringe air and rapidly they will create a by pushing this into the another syringe by mixing. So this is the video. Okay, I will show you later. So by using foam sclerotherapy, okay. So before this is appears like this, like the reticular telangiectasis of agenesis, and after subjecting for sclerotherapy, okay, this is a cosmetic effect. Okay, this is also foam sclerotherapy. This before it looks like this. After subjecting the patient for foam sclerotherapy, and on this cosmetic things will disappear. So one more entity, that is EVLA, endovenous laser ablation. Here the venous wall is distracted by using a laser technique. It involves the insertion of a laser fiber into the lumen of the incompetent focal vein with subsequent thermal ablation of the vein. Okay, so this image, this is the image. Okay, the generalization pushed into the truncal vein and laser energy they will use to distract the vein. Then radiofrequency ablation is fourth one. Here it uses a bipolar catheter to generate thermal energy to ablate the vein. Okay, here in the previous entity laser energy. Here by using thermal energy. Okay, this image shows the radiofrequency ablation. And by a catheter they will coming to the surgery. The principles of surgery are to ligate the point of junctional incompetence and to remove the reflexive trunk and the dilated tributaries. Okay, this is the principle of the surgery. Okay. In case of surgery, there are plenty of surgeries, but the principle is same. It involves all these things. Okay, you have to ligate the junctional incompetence. Siphonofemoral or siphonofemoral junction, you have to ligate it and remove the reflexive trend. That means vein vein, whether it is long or short thickness vein, if there is a reflexes there, you have to remove that whole trend and also dilated tributaries. Others also, if other venous bunches are there, you have to remove it. So there are variety of surgeries like saphenofemoral ligation and long venous stripping. Okay, that is also one of the surgery. So in this way, saphenofemoral ligation and stripping. Okay, here we will open the anesthesia. This is the long saphenous vein. They will tie it and even by passing the guide wire, we can remove this also. Again, this is also the surgical aspect. And saphenopopnatal junction ligation and lesser saphenous stripping also, and even perforator ligations. Whenever there is a, by doing reflex ultrasound, if they show multiple perforators, you have to directly at the site of perforators you can ligate it. It is called perforator ligations. And subfacial endoscopic perforator ligations. Here, before the perforator ligation, you will ligate by subcutaneous. Whereas in this surgery, okay, by subfacial, below the fascia, yes, the perforator is here to the creator, they will, while they will pigment, okay, they will do that. This is the endoscope, they will push it to subfascial, and they will identify the perforators and they will ligate it. It is called endoscopic perforator subfacial ligation. This is the image showing the this one. Phlebectomy. Phlebectomy means venous bunches. If there is a bunches are there, you can remove directly. This is the incision over the bunches. Usually performed in a small stab incision using small mosquito forceps or a phlebectomy tools. Okay, so this is the where mosquito forceps and they will remove the vein. Then one was catheter directed sclerotherapy and mechanico-chemical ablation. What is this? This involves a treatment device that is called an angled wire from the end. Okay, there is a cannula in there, there is a wire in there. Okay, it will actually, if you press the button, it rotates. The wire will rotate. Okay, this attached to a motorized handle. The catheter is placed within the vein movement as for endothelial ablation. The trigger the handle is depressed, spinning the wire around, and liquid sclerosing is infiltrated via the catheter simultaneously during the catheter withdrawal. Okay, here the tip, it rotates and it sprays the sclerosing material. The advantage of this mechanical thermoablation here is, it is thought that the spinning wire causes physical damage to the endothelium and allows a deeper penetration of the sclerosing into the vein wall. Okay, it is more effective than just home sclerotherapy, because here in this method you are destructing the endothelial layer of the vein. Then one more entity is endovenous glue. Okay, recently they are using this also. This involves a treatment catheter placed within the vein lumen. Again, a handle is used to create adhesive in 5 mm application via the catheter. The vein is then compressed, keeping the lumen closed. So, this is the glue instrument. This instrument is just, okay, they will load the glue after inserting the guide wire through the wire by using ultrasound. They will inject the glue into the main trunk of the vein. So there are variety of complications when you do open surgery. So you can expect complications. What are the complications? Like wound infections. Okay, it's one of the most common complications. And also nerve injury. Okay, the incidence of syphilis nerve neuralgia is up to 7% following long syphilis vein stripping to the knee. Okay, because this syphilis nerve always accompanies the long syphilis vein or great syphilis vein. And the incidence of sural nerve neuropraxia and common peroneal nerve injury may be as high as 20 and 4%, respectively, following short syphilis vein surgery, because short syphilis vein is accompanied by sural common peroneal nerves. Okay, when you are doing surgery, probability of injuring these nerves will be more. Okay. Then venous thromboembolic complications, but it is very less, it is 0.5%. Thank you once again. So I will show some of the videographs in relation to this varicose vein management. Okay. First one is, I already told, foam sclerotherapy. Okay. So foam sclerotherapy, so I already told, same the image what I told here, in one syringe they will use the sclerosing agent, they will prepare the foam and they will use it. Okay. So this method is useful for hyphen nerves or reticular veins in such conditions over the time. And this is for cosmetic purpose. Okay, so these are called hyphen nerves, or so they will inject via insulin syringe very small. This is a foam. Okay, this is foam sclerosing agent. Once they inject via intraluminal or peripherally, okay, it causes sclerosis of the surrounding tissue and the lumen, it obliterates. So this is a cosmetic surgery. This is called. So this is foam sclerotherapy. So this image is a foam sclerotherapy in case of management of varicose vein, especially presence of visible signs like telangiectasia or reticular veins. One more is endovascular laser ablation. Okay. So how they are doing? So this is an animated video showing endovascular laser ablation. Here first they will cannulate the vein, then via the vein, okay, they will insert the
catheter. Okay, among the catheter, at the tip of the catheter, okay, there will be a laser beam over there, and they will distract the vein. So this is called laser endovascular
laser ablation. So this is also here radio frequency ablation. In second unit, this is radio frequency. Here what happens? Heat energy will come. Okay? Here the catheter is different. Okay? In case of laser, it directs at the tip. Where the tip of the radio frequency, the energy discharges on the side way. Okay? So about 7 centimeters, they will discharge it. Again, they will dry and they will burn it. Okay? Like this, they will. That is called endovenous radio frequency ablation. Okay? So again, they will draw about 7 centimeters. They will identify by ultrasound like this. This is the videograph showing endovenous radio frequency ablation. And one more is ligation and stripping of the varicose veins. This is open surgery. Here what we are doing routinely, okay, this is the long saphenous vein. Here we will put an incision at the groin region, and then they will, after tying all the communicating branches, they will disconnect it. Then they will pass the guide wire here, and this is called ligation, and passing the guide wire will come here, then they will fix the mark, and this is called stripping. We will strip the vein. That means totally we will remove the vein. This is called ligation and stripping. This is open surgery. And then after that we will close the sides, the operating side. And this is also video shows the laser endovascular laser ablation. So this is the first they will cannulate the vein, then they will pass the guide wire, and over within the guide wire again they will pass the laser probe. Okay? So this is the laser probe. They will pass. Okay, here the laser energy. Okay, they will find the laser energy so that the venous wall will obliterate. So this is the videograph showing the endovascular laser ablation. So this is the block. After ablation, they will remove the catheter. So these are all minimum invasive techniques. So thank you once again. I will send this teaching material via WhatsApp to your class representative, and also I will give some homework to you. Once again, I will send few more questions. Please do those homework. Okay. Once again, thank you very much.